Welcome to CardioCast for Friday, November 1st. I'm Dr. Jim Dwyer. In this week's news, hypertension takes a heavy toll in black patients, cancer bumps cardiovascular disease as biggest killer in high-income countries, and virtual visits with newly discharged heart failure patients have their advantages. But before we start, we'd like to ask for your help in making this podcast better. Please take a moment to complete our short listener survey by following the link in the show notes. And now the news. Do you ever wonder how long your patients with new implantable cardioverter defibrillators wait to get behind the wheel? Or whether those who are commercial drivers stop driving altogether? That's what Dr. Jenny Jair and her fellow investigators wanted to know. So they plumbed Denmark's nationwide medical record database and sent questionnaires to nearly 4,000 patients with relatively new ICDs and got responses from 70% of them, she reported at the European Society of Cardiology's annual Congress. A European consensus statement calls for a 3-month driving moratorium when an ICD is implanted for secondary prevention or after an appropriate ICD shock, and a 4-week restriction when an ICD is placed for primary prevention. All these restrictions apply to personal driver's licenses. Anyone with an ICD is permanently restricted from commercial driving. U.S. guidelines are similar. The responses from ICD patients revealed that fewer than half of commercial drivers who received ICDs recalled being told they should never drive again professionally. And only 43% of primary prevention patients and 64% of secondary prevention patients stated they had been informed about any driving restrictions. Perhaps not surprisingly then, about a third of patients overall reported they began driving soon after they received an ICD, during the period when European guidelines recommend refraining from driving. Dr. Jair stressed that the driving restrictions are put in place because of the concern for an arrhythmia causing a loss of consciousness behind the wheel. Hypertension may be driving a significant portion of black adults' greater cardiovascular disease risk. About 1/3 of cardiovascular disease in black adults can be traced to hypertension, and the influence is much stronger in people younger than 60. That suggests early interventions to maintain normal blood pressure could reduce risk. Those are the key findings from a prospective cohort study published by researchers from the University of Mississippi in Jackson. Their research appears in JAMA Cardiology. Hypertension is the leading contributor to cardiovascular disease in the U.S., and non-Hispanic black adults experience it at a rate of 55%, higher than any other group. The researchers used data from more than 12,000 patients in 2 studies to determine the link between CVD and hypertension. They found that hypertension was independently associated with incident coronary heart disease, heart failure, and stroke. Patients with elevated blood pressure and hypertension were more likely to take cholesterol-lowering medication compared with those with normal blood pressure. Hypertensive patients were also more likely to have diabetes. We'll be right back after this message. Cardiovascular disease still accounts for 40% of deaths around the world, but cancer is eclipsing it as a cause of mortality in high-income nations. Dr. Salim Yusuf of McMaster University in Hamilton, Ontario, is the lead author of the PURE study. That epidemiology study looked at 202,000 people from 27 countries. When the researchers stratified cause of death by country income level, a striking pattern emerged. Fully 55% of deaths in high-income nations were caused by cancer, compared with 30% in middle-income countries and 15% in low-income countries. In contrast, cardiovascular disease was the cause of death 23% of the time in high-income countries. That figure rose to 42% and 43% for middle and low-income countries, respectively. What's driving the trends in high-income countries? Speaking at the annual Congress of the European Society of Cardiology, Dr. Yusuf offered an answer.
I think the main reason is we've made tremendous strides in reducing cardiovascular disease mortality, largely due to better treatment and better risk factor control. And so, obviously, other causes of death are increasing.
And finally, for patients transitioning to home after a heart failure hospitalization, substituting in-person visits with virtual video-based visits is feasible, safe, and may reduce appointment no-show rates. That's according to results of a randomized trial called Virtual Visits in Heart Failure Care Transitions, or VIV-HF for short. They were presented by Dr. Aaron Z. Gorudsky at the annual scientific meeting of the Heart Failure Society of America. He said that connecting patients with clinicians over secure video cut no-show rates at 7 days post-discharge by about 1/3, with no difference in risk of readmission, emergency department visits, or death, compared with the traditional in-person follow-up visit. Although the video meetup does not allow for a physical exam, it's still possible to collect history of what happened since hospital discharge, assess breathing, and complete other aspects of the follow-up visit. For example, during the virtual visit, patients are asked to hold their medication bottles up to the camera so the clinician can see what they are taking. Dr. Gorudsky said that frequently they were able to catch mistakes. He noted that most patients don't bring their pill bottles to the clinic, so in some ways doing the virtual visit for that aspect was more valuable. The investigators see the virtual visit as a screening platform. Dr. Gorudsky said that if someone seems to be doing poorly, you can always invite them to come in, but most patients post-discharge are not congested and they're doing quite well. Probably the more relevant issues are whether they have their medications and when their follow-up appointments are. You can find these stories and more by visiting www.mdedge.com/cardiology or by clicking the links in the podcast notes. This week's contributors include Andrew Bowser, Jim Kling, and Kari Oakes. And CardioCast Cardiology News and MDedge Cardiology are edited by Catherine Hackett. Remember, you can find CardioCast via Amazon Alexa, Apple Podcasts, Pandora, or wherever you listen to podcasts. And if you like what you hear, please leave us a rating or review. And be sure to take our short listener survey. For MDedge, I'm Dr. Jim Dwyer.